Well, good morning, ladies and gentlemen. So, as Snehal has said, today we will concentrate on the conduction system, but we'll also talk about the conduction system in the subsequent topics in the setting of congenital malformations, very interesting congenital malformations, Ebstein's malformation, and then congenitally corrected transposition. So, to put this into context, we need to know about the electrics of the heart. And nowadays, the electrophysiologists probably know more about the electrics of the heart than I know about the conduction system itself. And oftentimes, I'm asked questions now that I can't answer. But I know where the normal conduction system is, and that's the starting point. We're still working out where the abnormal rhythms might come from, and we'll discuss some of the potential substrates for arrhythmogenesis as we go through. But if we assess the normal electrics of the heart, you're all well aware that it is the sinus node that generates the cardiac impulse. The cardiac impulse then passes through the atrial myocardium, and it is the passage of the impulse through the atrial myocardium that generates the P wave. Now, almost certainly, the electrical impulse reaches the atrioventricular junction prior to the atrial chambers having contracted and pushed blood across the atrioventricular junctions. So if the ventricles are to fill properly, we need time for that blood to get into the ventricles, and that's why we need atrioventricular delay. So the structure that produces atrioventricular delay is the atrioventricular node. And the atrioventricular node is located here at the base of the atrial septum. But if the atrioventricular node is to work properly, it is of course essential that around the remainder of the atrioventricular junctions, the atrial myocardium is insulated from the ventricular myocardium. And that is a key to the understanding of normal conduction, that aside from the passage of the atrioventricular conduction axis through the insulating plane, the remainder of the atrial myocardium is insulated from the ventricular myocardium. But if everything goes normally, the atrioventricular node does its job, it delays the impulse, and then when the ventricles are suitably filled, it passes through, and then the impulse passes all the way down the ventricular conduction tissues so that activation takes place from the apex towards the base, driving the blood into the arterial trunks. And the ventricular activation itself, of course, gives us the QRS complex. Then we have the repolarization phase with the T wave. And nowadays, you know more about the electrocardiogram, and the inferences that can be made from the electrocardiogram are quite amazing. So, what do we need to know if we are to understand the conduction system? The first thing, again, is the need for attitudinally correct descriptions. And we discussed yesterday how clinical cardiologists are very reticent to accept the evidence they see before them with their own eyes. This is particularly true of electrophysiologists. And quite some time ago now, in the late 1990s, a Spanish electrophysiologist called Paco Cosillo, who may well be known to some of you, pointed out that when he was in the electrophysiology laboratory one day, he was pushing the catheter up from the inferior caval vein, and as it went up from the inferior caval vein, it entered the right atrium, and he said to his fellow, "As you see, I am passing the catheter anteriorly." And the fellow said, "Hang on a moment, Dr. Cosillo, the catheter is going superiorly." And this, of course, was because electrophysiologists, like ourselves, for years have considered the heart as tipped forward and sitting on its apex. So Cossio said to me at one of the meetings, we have to resolve this. And we created a committee in Europe, which was supported by the European Society of Cardiology in Hein Wellens. Yashi's mentor was part of that committee. We also convened a committee in North America. We published papers recommending the nomenclature. They were published in the European Heart Journal, published in Circulation, and nobody has taken any notice of them whatsoever. But we have to change, because for the young ones amongst you who want to learn about these things, it makes so much more sense to explain the electrics of the heart in the setting of attitudinally appropriate description, because I said yesterday, the electrocardiogram doesn't tell lies. So I'll say a few words about the attitudinally correct approach, and then we'll move on to the conduction tissues. I'll tell you how we recognize them and where they are located. So here we have a man standing upright in the anatomical position, and I've shown you the picture of the heart as you would see it in left anterior oblique projection. But even if it's left anterior oblique projection, we should still describe it as from the right side to the left side, the head to the feet, superiorly and inferiorly, and then the spine towards the sternum, with the spine being posterior, the sternum being anterior. And I showed you this picture yesterday. It's the short axis of a normal heart, and I've positioned it as you would see it in left anterior oblique orientation. And you all know full well that the inferior surface of the heart lies on the diaphragm. And so the part of the heart that is closest to the diaphragm should logically be described as being inferior. The part of the heart that is closest to the spine is posterior, and that is the back wall of the left ventricle. It is not the inferior surface of the two ventricular chambers. The anterior wall is the part that is adjacent to the sternocostal wall, and the superior part is closest to the head. If you go into the papers that frequently are written now, the textbooks that show you what is happening within the heart, electrophysiologically, and I am no exception to this. Many of my own pictures of the heart have been totally wrong. We should go back and see how Koch, in his original illustration, showed the triangle we now name after him. And so this is the picture taken from Koch's original paper. I'm going to show you in a moment the location of the sinus node. It's exactly where Koch pictured it. But what we need to look at here is the atrioventricular node. And you see that Koch has drawn his triangle with its apex pointing upwards. It is a fundamental mistake to show the triangle of Koch with its apex pointing to the right. When the heart is attitudinally aligned, as you see here, the apex of the triangle of Koch points upwards, and then the inferior caval vein, the superior caval vein are one on top of each other, and as Cossio pointed out, when you pass a catheter up the inferior caval vein, the catheter passes superiorly as it enters the right atrium. And when I demonstrate the heart shortly, I'll emphasize these points. So what we need to do, we need to describe the conduction system as we see the heart within the chest. But if we're going to do that, first of all, we need to know what is the conduction system. We call the conduction system the specialized system, but in a way, it is the working myocardium that is specialized, because every cardiomyocyte within the heart has the capacity to conduct. And potentially, every cardiomyocyte within the heart has the capacity to trigger an abnormal rhythm. but we know that some of those cardiomyocytes are specialized such that their function is to generate the impulse and then to conduct the impulse. There have been a lot of controversies with regard to those that conduct the impulse through tracts. So the paradigm for a conduction system, now we recognize, should be the ventricular system of Tawara. Tawara was the young Japanese who in 1906 came to work with Ludwig Aschoff in Marburg in Germany, and he described the tract I'll show you in just a few moments. And then, subsequent to controversy, after the publication of Tawara's work, the giants of German pathology, Munkeberg and Aschoff, produced criteria for conducting tracts. Because at that time we were recognizing the tracts using histology. We still do that, and I'll show you that. But these giants pointed out that a tract should be insulated. And that is the real key as to how we as anatomists differentiate tracts. They should also be histologically distinct so that you can recognize the cells within them. And most importantly, we should be able to take serial sections through the heart, and if there is a tract, we can follow that tract with its sheath of insulation from one section to the next. And this is the gentleman who clarified the whole thing, a handsome young Japanese, Sunao Tawara. He was from Fukuoka, which is in the southernmost island of the Japanese archipelago. He was funded by his father to go and work with Ludwig Aschoff. And when he arrived in Marburg, he was set the task of finding the histological substrate of cardiac failure. Well, we're still looking for the histological substrate of cardiac failure. I'm sure Pradeep is not able, when he looks at the histologic sections, to be sure why the heart is failing. So Tawara was unsuccessful in his search for the source of cardiac failure, but what he did do was clarify the electrics of the heart. And this is one of the exquisite tinted drawings that come from the monograph that he produced. I've reorientated this to show it to you in attitudinally appropriate fashion. And what Tawara did was he showed the only pathway in the normal heart that conducts the impulse from the atrial to the ventricular chambers. In yellow here, he has pictured atrial myocardium, and he noted this little knot of tissue that he called the conduction. We now call that the Atrioventricular Node. And he observed how the conduction continued through the insulating plane. This was the structure that Hiss had described 13 years previously, but nobody could understand the description of Hiss. It was Tawara's work that clarified the arrangement, because he showed that the axis continued through the insulating plane, and then it branched on the crest of the muscular septum as the ventricular bundle branches. And the Englishman who subsequently, in fact the Scotsman, who subsequently found the sinus node, having read Tawara's monograph, made the point, with the publication of this book, Tawara ushered in a new epoch of the understanding of cardiac structure and cardiac function. And I think that is absolutely true. The work of Tawara is amazing. And he showed the importance of using histology. So here is a section through the ventricular septum. And you can see that within the ventricular septum there is a little bundle of cells. And those cells are histologically distinct. If we take serial sections, we can trace that bundle as it moves from the apex, from the crest of the ventricular septum towards the apex. And most importantly, if you look carefully, you see there is some green tissue that is interposed between the bundle itself and the adjacent working myocardium. And this, of course, is the right bundle branch. And it is part of Tawara's tract of conduction system. And for quite some time, I thought that these criteria established by Munkeberg and Aschoff worked for all of the conduction system. But I've now realized that that is not the case. So this is the structure that a year after Tawara published his monograph, Arthur Keith and Simon Flack discovered within the atrial tissues. It is the sinus node. And what you see here is the working myocardium of the terminal crest. We'll look at that at the moment in a heart. There is the working myocardium of the superior caval vein. But again, looking at this histological section, you can see that there is an area here that is histologically distinct. The cells making up this small area are quite different from the working myocytes of the terminal crest, the superior caval vein. If we take histologic sections, as with the right bundle branch, we can trace it from slide to slide. But the myocytes of the sinus node are not insulated from the adjacent myocardium. In fact, it would be a nonsense if the heart insulated the sinus node, because there would be no way then for the impulse generated within the sinus node to reach the adjacent working myocardium. And we know on occasion that adipose tissue can infiltrate around the borders of the sinus node and can stop the sinus myocytes activating the rest of the myocardium, and that gives us the so-called sick sinus syndrome. So we have to modify the original criteria, and we have to do the same thing for the atrioventricular node. So here you see the tissue that Tawara recognized as being the connotum. Atrial myocardium to your left hand, ventricular myocardium to your right hand. And this is a section in which the connotum is insulated from the ventricular myocardium. So there is the connotum, the atrioventricular node, once more, histologically distinct, traceable, but not insulated from the myocardium. So now it has been necessary for me to modify the criteria I use for histologic recognition of the conduction system. The nodes are histologically discrete and traced from section to section, but they are not insulated. The nodes are not tracts. It is the atrioventricular conduction axis, which is the tract, which, if conduction is normal, ensures that the impulse is delayed in the atrioventricular node, disseminated through the bundle branches. And it is that axis that fulfills the three criteria initially suggested by Aschoff and Munkeberg. Now, there are ongoing controversies regarding the substrates for arrhythmias. We're still searching for the substrate for atrial fibrillation. And there's been a lot of nonsense written in the literature about specialized cells in the pulmonary veins. And the reason that there is nonsense is because the people who claim that those cells in the pulmonary veins are specialized have not read the early literature. And I think these early criteria, established by Tawara, endorsed by Aschoff and Munkeberg, are just as valid today as when they were published in the first decade of the 20th century. So I think if we are going to solve the mysteries of arrhythmologists, which is what Yash is trying to do, which Shomo is trying to do, it is essential that when we make our clinico-morphologic correlations, we follow these criteria. And I'll come back to that at the end of my presentation to you. So let's go back now and see if we can put the location of these nodes and the conduction axis back into the heart. So this is a picture that was taken in the operating room by my close friend Benson Wilcox, sadly no longer with us. I've reorientated it so it is attitudinally appropriate. And there you see the terminal groove. Dr. Deshpande yesterday showed you beautifully the terminal groove. She called it the sulcus terminalis because old habits die hard, and she's been teaching in Latin now for very many years. I hope I can persuade you in the future to think of it as the terminal groove. If we look within the terminal groove, oftentimes we can see a little cigar-shaped structure. And in most instances, it is inferior to the crest of the atrial appendage, which I'll show you very shortly. And if we take a section across that terminal groove in that location, then we find the sinus node. Now, there's a lot more nonsense still existing in the literature showing these entities, so-called specialized internodal tracts. When I was in Amsterdam a long time ago, when Hein Wellens was still in Amsterdam in 1974, I worked with an outstanding experimental electrophysiologist who still works there called Giel Janse. I'm sure Yash has met Giel Janse. And we wrote a paper called Specialized Internodal Tracts, Fact or Fiction. And we showed that, in fact, these so-called tracts were fiction. They are the result of the vivid imagination of an American cardiologist who was called Thomas N. James. And James had suggested these tracts were specialized, and we had another friend at the time who was an anatomist, and he was talking about Thomas N. James, and he said to us, to Anton Becker and myself, "Do you know, Thomas James has a horse that can climb trees?" And we said, "That is fantastic." He said, "Yes, if you go down to Birmingham, Alabama, he'll show you the tree." And it is exactly the same with the internodal tracts. Dr. James cannot show you the tracts because they don't exist. They bear no resemblance to Tawara's insulated tracts. So here is a section I took a long time ago from an infant heart, and even at this low power, you can recognize the sinus node, you can recognize the atrioventricular node, using the criteria I've put before you. The tissue between is ordinary working myocardium. And it is the alignment of the working cardiomyocytes that determines the rate of preferential atrial conduction. So let's move on and let's look at the atrioventricular node. We have key landmarks that tell us where we find the atrioventricular node. When hearts have a eustachian valve, and it's not always present, but if you put tension on the eustachian valve, then a tendinous structure springs into prominence that inserts cranially into the central fibrous body. And if we then look for the hinge of the leaflet, septal leaflet of the tricuspid valve, and we look at the location of the coronary sinus, then together we have put the landmarks of the triangle of Koch. Now, if we then take a heart and we remove the non-coronary sinus of the aorta, so here you're looking down on the base of the heart from the atrial aspect. This is the mitral valve, this is the tricuspid valve, and I've removed the non-coronary sinus of the aorta. You see that the apex of the triangle of Koch is directly adjacent to the membranous septum. The membranous septum itself is divided into two parts by the hinge of the tricuspid valve. The conduction axis penetrates through the atrioventricular component and reaches the crest of the ventricular septum. So if I make a drawing what I've just shown you, in green there you see the insulating tissues, the area of aortic to mitral fibrous continuity continuous with the membranous septum. And if I blow up that middle part, you can see how short the bundle of His is to pass from the apex of the triangle of Koch to reach the crest of the muscular ventricular septum. And this area beneath is the inferior pyramidal space, and running through that we have the coronary sinus, which, as we discussed yesterday, is a landmark of the morphologically left atrioventricular junction, even though it empties into the right atrium. So, the landmarks of the triangle of Koch: at its apex we have the membranous septum, the conduction axis penetrates through that, and this is the inferior paraseptal area. And this is how we should describe it attitudinally. It is not posterior, it is inferior, and it is paraseptal, because we can lift away the vestibular myocardium of the right atrium from the summit of the ventricular mass, and there is an epicardial tissue plane running all the way through this inferior pyramidal space, separating the atrial from the ventricular myocardial masses. So we position the triangle of Koch with its apex uppermost, and then if we take sections through the triangle of Koch, we can see the atrioventricular node separated by the central fibrous body from the ventricular myocardium, with transitional cells feeding its atrial surface. But then, if we go a little more cranial, we find the bundle of His. And the bundle of His here, in a beautiful section, you see, is surrounded by the fibrous tissue of the central fibrous body. As soon as the axis enters the insulating planes, it is no longer able to respond to atrial events. Now, one of the things we're going to be discussing this morning is how to avoid the atrioventricular node, and the surgeons now are well aware that when the heart is in the operating room, the patient is in the operating room, this time the triangle of Koch has its apex pointing to the left. This is another of the beautiful pictures taken by Benson Wilcox, my late lamented colleague. You see that he has a little probe in the coronary sinus, and what we are looking at there beautifully are the landmarks of the apex of the triangle of Koch. The atrioventricular node will be there. If the surgeon respects the landmarks of the triangle of Koch, he will never, or she will never, damage the atrioventricular node. So this is how I look at it as a morphologist, and this is what I'm going to show you in just a moment. The heart again is attitudinally aligned so that the triangle of Koch has its apex uppermost. And to find the atrioventricular conduction axis, we draw a line from the apex of the triangle of Koch to the medial papillary muscle. The left bundle branch is then descending on the left ventricular aspect of the septum. And we cannot do better to understand the arrangement of the left bundle branch than to go back to Toara's original monograph, and this exquisite picture is just one of the offerings from his monograph. You see here the right coronary leaflet of the aortic valve, and look how close the anterior margin of the left bundle branch is to the nadir of the right coronary leaflet. It's not surprising when you put prosthetic valves underneath the aortic valve that they lie on the left bundle branch. And this is the information we were discussing yesterday evening. Now, we cannot leave the conduction tissues without considering one more feature. Because in 1893, when Wilhelm His described the bundle that now bears his name, another physiologist called Stanley Kent suggested that in the normal heart there were multiple pathways for conduction. And Kent was 100% wrong. But when we found that there could be anomalous pathways that produce Wolff-Parkinson-White syndrome, for many years, electrophysiologists called these bundles of Kent. That also is fundamentally wrong because Kent never described any bundles. This is what Kent described. And there is something here that deserves recognition. And if you look very carefully, you see that Kent, in fact, didn't label it as a bundle. He labeled it as a node. But we now know that these nodal remnants are always insulated from the ventricular myocardium in the normal heart. And they do exist. So this is one of the sections made by Anton Becker. It's the insertion of the vestibular myocardium at the right atrioventricular junction. And there is one of the node-like structures examined by Kent. But in the normal heart, they never make contact with the ventricular myocardium. But we can now explain where they come from. So here is the basal surface of the heart looked from the atrial aspect, mitral valve, aortic valve, tricuspid valve. And this is the basis on which I produced this drawing that I showed you quite some time ago. But now I want to show you the location of the ring of tissues that represent those nodes seen by Kent. Initially, this is a ring, but as the heart develops, it becomes remolded into the figure of 8 that you see there, that surrounds the tricuspid valve and surrounds the subaortic outflow tract. And we call that the primary ring. And the atrioventricular conduction axis is part of that ring. But we now know that remnants of the ring can exist anywhere within the pathway that the initial ring took during its embryologic development, and usually the ventricular part disappears. The atrial part can persist as those remnants that I showed you. So it is only the atrioventricular conduction axis that is always present, but we see these remnants of ring tissue. But we now know that there is also a particularly well-formed component of the ring that sits in the atrial septum directly behind the non-coronary sinus of the aortic valve. And so there you see what has happened to the ring. The atrioventricular conduction axis now in blue, and there is this remnant that sits directly behind the non-coronary sinus of the aortic root. And this is the structure that Yash and Shomo, together with Eduardo Sternik, Hein Wellens, and myself, has suggested is the substrate for some of those rhythms that can be ablated from the non-coronary sinus of the aortic root. Yash has now told me that he can also ablate, or at least he's ablated one rhythm, from the left coronary sinus. And if we look carefully at this, Yash, we see that there is part of the ring that is adjacent to the left coronary sinus. So it is possible that there could be something there, and we'll have to explore that further, because initially the aortic ring also here is at the base of the left coronary sinus. But this is what we have looked at the moment. This is a mouse heart, the non-coronary sinus of the aortic root, the right atrium, the left atrium. This is the front of the atrial septum, and if I blow that up, there is no question but that this structure does exist. As you see, it is histologically distinct, traced from section to section, but not insulated from the myocardium. So the very presence of that retroaortic node pointed us towards a potential origin for some abnormal rhythms. Shomo and Yash know that even with the evidence we produced, there were some cardiologists we could not convince, but we rebutted their criticism in forthright fashion. We now have to look further because there are other mysteries that as yet we still have not solved regarding the origin of abnormal rhythms. And if we are to solve those ongoing problems, I believe we still need to take note of these old investigations that I put before you today. But with regard to the discussions for the rest of today, I do believe that the knowledge of development permits us to predict where we will find the conduction tissue with great accuracy, even when the heart is congenitally malformed. So I'll now move on, and I'll demonstrate you to a normal heart and illustrate where we can find those conduction tissues. So can we come the other way around?